Okay, Dr. Ode, if you are ready, we can start.
Yes.
Yeah, start, please.
Hello, good day.
Hello, doctor.
My name is Dr. Uday, one of the doctors in the clinic. Am I talking to Mrs. Ahlam Ahmad, 28-year-old? Hello?
Yes, Dr. Ode.
Yes. It came to my knowledge that you have been troubled with weakness of your left side while being in the hairdresser. We are here to discuss this issue with you. Is it okay?
Yes, doctor. Sure.
I will write some notes and will be strictly confidential, and this is only for medical record.
Definitely, doctor.
Could you tell me what happened with you, Mrs. Ahlam?
Yes, doctor. Actually, I was in the hairdresser preparing for my friend's wedding. And then, doctor, suddenly I developed weakness of my arm. Suddenly I dropped the cup of coffee, doctor. And then I panicked and I called the ambulance. This is really scary.
I feel sorry for that, Mrs. Ahlam. Any previous episodes like that?
No, doctor, it is the first time.
Right. For how long does the weakness persist?
Yeah, just like 10 minutes. And by the time the ambulance arrived, already I felt better, doctor.
Right. Where does it involve in your body?
The left side, doctor. Left arm.
Right. What was you doing exactly in the while being in the hairdresser?
Yes, exactly. I think, Dr. Uday, your voice is interrupting. I don't know whether the problem is from my side or your side.
Right. You are hearing me
is
right
my voice
now?
Clear?
Yes, your voice is clear. Do you hear me right now?
Okay, I can hear you. Yes, you can continue, please.
Right. Do you extend your neck while being in the hairdresser?
Yes, doctor. Beforehand, I was extending my neck.
Any neck pain before the weakness?
No, doctor.
Any trauma to your neck or any part of your body?
No, doctor.
While you have the weakness, do you lose your loss of consciousness?
No, doctor.
Any history of fits?
No.
Any headache?
Yes, doctor.
Any headache preceding the weakness?
No, doctor. Headache started actually after the weakness.
Right. Any vision problems?
No.
Any abnormal sensations involving your any part of your body?
No, doctor.
Any difficulty with speech?
No.
Sorry, I'm sorry to ask you this question. Any loss of control over your water work?
No, doctor.
Any loss of control over your back passage?
No.
Right. After when the weakness settled down, do you develop any kind of does the headache persist?
Yes, doctor. I still do have the headache now.
Right. Any history of confusion after the weakness?
No, not really, doctor.
Right. Do you fall down or develop any kind of trauma?
No.
Right. Any past medical history? If not, I should be aware about it.
Not really, doctor.
Right. Any history of chest pain?
Chest pain, no, doctor, but I do
Any
get frequent headaches. I do
Right.
get frequent headaches, doctor, yeah.
When did this headache started exactly?
Like many years back, doctor.
Have you been diagnosed?
No, doctor, I just go to my GP, and whenever I have the headache, he will give me some medications, and it will help usually.
Where is the site of the headache exactly?
The current headache, you mean?
The past episodes of headaches.
The past episodes of headache is different, doctor. Sometimes affecting half of my head, and sometimes all of my heads.
Is it throbbing in nature?
Yes, sometimes, doctor. Sometimes throbbing, sometimes dull aching.
Right. And the current episodes of headache, is it the same or different?
It's a little bit different, doctor. This one is severe, and it's also affect all my head.
Right. I feel sorry for that, Mrs. Ahlam. Any racing of your heart, please?
No, doctor.
Any difficulty of breathing?
No.
Any history of difficulty of swallowing?
No.
Any tummy pain?
No.
Any change of your bowel habits?
No.
Any weather preferences?
No, doctor.
Any change of your water work?
No.
Any history of lumps or bumps anywhere?
No.
Any weight loss?
No, doctor.
Any history of feeling sickness?
Sometimes, doctor, with the headache, I do feel sick, but currently I do not feel any sickness.
Right. Any episode similar? Any episode similar? Any one of your family have the similar episodes?
You mean the headache or weakness?
The weakness.
The weakness, yes, doctor. I remember my mother. When she was 55, she developed a stroke, doctor, and this is really concerning me. And she was, as I remember, receiving a medication called warfarin for that.
Right. Any history of sudden death at your family?
No, doctor.
Any diseases any disease running in your family?
Like what, doctor?
Any familial diseases, which is diseases that run from generation to generation through specific codes?
Not to my knowledge, doctor.
Right. Do you smoke, Mrs. Ahlam?
Yes, I do.
How many cigarettes?
Around just 2 cigarettes, doctor.
For how long?
For the past one year.
Actually, Mrs. Ahlam, smoking is quite injurious for your health, and it's strictly advised that you stop smoking. And I can help you in this regard by referring you to a smoking cessation clinic.
Okay, doctor, I will try to stop.
Right. Do you drink alcohol?
No, I don't.
All right. Do you have any particular hobbies?
Not really, just going out with friends, doctor.
Right. What do you work, Mrs. Ahlam?
I study for my MBA, doctor.
Right. Do you drive?
Yes, I do.
Right. What kind of a small vehicle or a large vehicle?
It's a normal vehicle, doctor.
Right. Any history? And you mentioned that there is no history of trauma.
No history of trauma, yes.
Yes. Could I ask you a private a question about your period?
Sure, doctor. It's okay.
Is it regular?
Yes.
When was the last period?
Around 10 days ago, as I remember, doctor.
Right. Are you in long-term relationship, Mrs. Ahlam?
Yes, I've got a boyfriend.
All right. Do you have children?
No.
All right. Any history of? Do you try to have children?
No, doctor.
Right. Do you take any kind of birth control pills?
Yes, I do. I do take birth control pills.
Right. Any history of blood clots?
No, doctor.
Right. Any history of recent travel?
No.
Please show me your medication list.
It's only the birth control pills, doctor, and occasional over-the-counter painkillers. That's all.
So, could I ask you a private, a sensitive question that I ask to my patients?
Sure, doctor. It's okay.
Any history of taking illicit drugs?
No, doctor, at all.
Right. I would like to ask you some questions about the episodes of headache that you are suffering prior to the events.
Sure, doctor.
How frequent do you develop attacks of headache?
Not too frequent, doctor, but just during the previous months, it started to increase. I don't know why.
Right. Any stress at your life?
Maybe, doctor. As I mentioned, I was recently preparing for my MBA and I have exams, so possibly yes, I'm a little bit stressed.
Right. When you develop or prior to the developing the episodes of headache, do you feel like any abnormal weakness at any side of your body?
It was the first time to feel this weakness, doctor.
Right. Any abnormal visions like seeing floaters?
No, doctor.
Any abnormal sensations prior to the headaches?
No, doctor.
Any abnormal smell?
2 minutes remaining.
Right. So what's
doctor.
What's your concern, Mrs. Ahlam?
Yes, doctor. What's wrong with me? What do I have a stroke?
I highly appreciate your concern, Mrs. Ahlam. From what you have said to me, most likely you have a mini stroke that develops after you were extending your head, and have many reasons. One of them, the position that you developed, that you had extending your neck, may make your one of the major vessels in your neck to let's say have a tear, leading to the symptoms that you have. And other causes, you have a history of headache, which seems to be a migrainous headache, which is a type of long-standing headaches, and you are taking a birth control pills, and these are associated with a risk of developing a stroke. You also, as a smoker, and your mother has a history of stroke. What we need to do is to examine you thoroughly, do some investigations, and I need from you to currently stop driving until you will be assessed thoroughly. Any further concerns, Mrs. Ahlam?
Just regarding the birth control pills, I don't know if this is relevant, because I read in the internet that it might increase the risk of developing clots.
Yes,
shall I stop them, or?
Yes, I said to you, I need for you to stop the birth control pills, and I can arrange a meeting for you with a woman doctor to give you an alternative method of contraception.
Okay, doctor.
Any further concerns, Mrs. Ahlam?
No, doctor. Thank you. Time up. Okay, we'll give you 1 minute for reflection before we start questioning. Okay.
All right.
Okay, doctor. So, can you take me through your case, please?
Female patient, 28-year-old, has a history of recurrent attacks of headache, taking birth control pills, developed a sudden onset left-sided weakness that persists for 10 minutes and resolved completely while extending her neck in the hair dresser.
Okay.
And her vitals are stable.
Okay, excellent. So what do you think the cause of her weakness here? Any differentials you have?
Here, the case is around stroke in the young patient. Most likely, I'm thinking about dissection. Another differential.
What does support carotid dissection or cervicocephalic dissection in this particular case, apart from being in the hairdresser and extending the neck? Anything else you were able to identify?
Neck. I think she mentioned neck pain.
Okay.
Neck
she
pain.
denied neck pain and swelling, basically.
She denied neck pain, right? She denied neck pain.
Okay.
Right.
Okay. Okay. So apart from cervicocephalic dissection, what else you would want to put in the differential diagnosis?
Hemiplegic migraine.
Complex migraine. So
Yes.
which one you would put on top of the list? TIA or hemiplegic migraine?
I'm considering the dissection.
Dissection.
Yes.
Okay. So how can dissection cause TIA?
Dissection cause TIA. I'm not aware about the exact mechanism.
Okay, no worries. So any other differential for the TIA in this particular patient? You mentioned cervicocephalic dissection. Any other differential you would like to consider?
Well, carotid sinus hypersensitivity, it may present it with loss of consciousness or syncope.
Excellent. Exactly.
Not
exactly.
left-sided weakness.
So, exactly. So what else you would like to consider?
Other causes like cardioembolic from arrhythmia or structural heart disease. Also, LSD drugs.
What again is thromboembolic complications and in this case, in this particular case?
She denied palpitation or chest pain.
Okay. And she denied fever as well, right?
What?
Okay, excellent. So how would you like to investigate this patient?
Basic and specific. Basic in the form of CBC, RFT, LFT, and inflammatory markers, and specific. I need to do brain imaging, brain.
Which one?
Brain CT or brain MRI. Brain.
Which one is more suitable in this case?
Right. I will do in brain MRI. It will be more sensitive to rule out acute stroke. Okay,
excellent. So looking for what?
Looking for infarction or hemorrhage.
Apart from TIA. Okay. What
looking
else?
For infarction or hemorrhage. And CT angio for the neck.
Excellent. Anything else?
I want to do ECG and probably Holter monitor. Detecting occult arrhythmia, occult AF. And 2D.
Okay, so how are you going? Okay, how are you going to manage this patient?
I will refer here to a team of specialized doctor involving the nerve doctor and physiotherapy and the management will be non-pharmacological and pharmacological, non-pharmacological, education, psychological support, and addressing the risk factors and a reduction of it, stopping smoking, advising it to stop smoking, and pharmacological. After, if we diagnose here with the dissection, we'll consider imaging and maybe, and if you confirm dissection, it will be managed in liaison with the vascular surgeons.
Okay, so one of your differentials was complex migraine.
Right.
Okay. Any medications you'd like to start this patient on to prevent the recurrence of migraine attack?
Yes, beta blockers.
Okay, well done. You can move to the next session. Thank you, Dr. Ade.
Thank you.
You did great, by the way, but at the last second, you took the bait. ابتلعت الطعم. Beta blockers are contraindicated in patients with complex migraine. Take
Right.
care. Take care. Okay.
Okay, sir.
So, are you happy for me to comment on everything? By the way, you did very nice. I guess today you are in a good mood. You did perfect, really.
Thank
But
you.
still, I have got just tiny comments because I am happy with your performance. So I would like to
Definitely,
push you
sir.
to reach perfection. Okay.
Definitely, sir.
So starting from the introduction, you mentioned, hello there, my name is Dr. Uday, one of the doctors in the clinic today. If you check the scenario, it is written doctor in AMU, which is the emergency room, emergency department, or acute medical unit.
All right.
Okay, so take care, it is not always a clinic. If they mention like cardiology clinic, neurology clinic, nerve clinic, whatever, you can mention in the clinic today. But sometimes it is the doctor in the ward, in the medical ward, in the emergency room. So just take care, okay?
All right.
Then you started by telling her, came to my knowledge that you are suffering from left side weakness. Can you tell me more about this? This is okay and this is fine, but it would be better if you ask an open question. What brought you to the hospital today? What brought you in here? What is your problem? Give her open question. What is the difference? If you ask her about the left side weakness, you will start speaking about the left side weakness because this is closed question. But if you ask what brought you in here today, what is your problem, she might volunteer the weakness as well as other important information, like, for example, the headache.
Right.
From the start, okay? So you will put the differential diagnosis of complex migraine from the start. This is very important. I cannot stress more. Whether you are dealing with station 5 or station 2, you have to start by an open question and keep your open question wide open. What brought you into clinic today? Never speak about particular complaint. Let the patient elaborate more on what brought him to you. Okay, this is because sometimes from outside, for example, they will give you a complaint, but inside, the main complaint, which is of great concern to the patient, is different. Okay, so it is sometimes dangerous to omit the open question. Okay, even after the open question, after she started to tell you, for example, about the weakness, still you can add another open question. This is not station 5. This is station 2. You have got long time. Okay, tell me more about it. Regardless of whether she mentioned headache, she mentioned weakness, tell me more about it. She will start to volunteer more important informations. Okay, so doctor, I have got weakness affected my left side. And also I have got horrible headache. Okay, so tell me more about it. Starting, for example, by the weakness or starting by the headache. Doctor, I was in the hairdresser preparing for my friend's wedding, and then suddenly I started to have left side weakness. I dropped my cup of coffee. By the way, there is a trick here. Can you think what could be the trick here? This patient has got migraine, okay, and she continued to drink caffeine. There is a possibility that she is drinking a lot of caffeine. That's why this was one of the triggers which precipitated the migraine attack, right? So
Yes.
if you do not give her advice regarding caffeine, chocolate, and cheese, this might affect your clinical judgment because your plan is never sensible unless you tell the patient to avoid the triggers.
Right.
Okay, so they never give you any information, any word in the scenario or from the surrogate unless for a purpose. Take care. So, doctor, I dropped my cup of coffee suddenly. I developed weakness of my left side, my left arm. Okay, so I panicked and I called the ambulance. Okay, so what should be the first question here? Is it the first time to have this weakness? Is it the first time to have this headache? By the way, especially when your complaint is abdominal pain or headache. PACES-wise or something else? PACES-wise. We are speaking PACES-wise. PACES-wise, if your complaint, the main complaint is headache or abdominal pain, the most important question is going to be, is it the first time or not? Because if it is headache and it is recurrent headache, it is not the first time, this equals migraine. PACES-wise equals migraine, full stop. If it is abdominal pain and it is not the first time, PACES-wise, it equals FMF, familial Mediterranean fever. Familial Mediterranean fever. Okay, so the question of whether this complaint, okay, whether this is the first time or not is very important. Okay, and then I am going to start by analyzing the weakness. You mentioned started only today. Is this the first time? Yes, it is the first time. How did it start? It started suddenly, doctor. Okay, and then for how long did it last? For around 10 minutes. By the time the ambulance arrived, already the weakness improved. Do you have any residual weakness at all? This question is very important. Why? Because it will identify TIA, right? If the weakness did not resolve till now, maybe she's developing stroke. This is something else. No, doctor, currently there is no any residual weakness. The weakness lasted 10 minutes and improved completely. So here we are between complex migraine and TIA. TIA itself, it has got a differential here. But so far, we know this patient is either having TIA or complex migraine. Why? Because the weakness improved spontaneously and in just 10 minutes. So which one you would like to start analyzing, the headache or the weakness? It won't make any difference, by the way. Anyhow, let us start by analyzing the weakness. Okay, so as we mentioned, when did it start? Today. How did it start? The onset, sudden. How did it progress? Only involved the left arm and then improved. For how long did it last? 10 minutes. Any residual weakness at all? No, doctor. So here, the most important next step is to complete your Reuters score or Rosier score. Recognition of stroke in the emergency department score. Recognition of stroke in the emergency department score. Okay. As per the new guidelines, NICE guidelines, published July 2019, okay, they started to introduce this scoring to identify the probability of TIA and stroke. Okay, so this is scoring, there is points, okay, for one side arm weakness, this is +1. One side leg weakness, this is again +1. One side facial weakness, again +1. Speech problem, +1. Vision problem, again +1. Then you have got loss of consciousness or syncope, -1, and seizure activity, I mean convulsion, -1. If the score is +1 or more, you cannot exclude TIA at all. TIA is highly probable. Okay, if it is 0 or -1 or -2, TIA is less likely or unlikely, but anything which equals +1 and more, TIA is never excluded. You cannot exclude it. Is it clear? Is it clear?
Yes, sir.
Okay. So after analyzing the weakness itself, you have to ask about also weakness of the leg, weakness in the face, changes in the speech, changes in your vision, loss of consciousness, fits. I believe you have asked about everything except the leg weakness. You did ask about loss of consciousness. You did ask about, I don't know whether you asked about symptoms of hypoglycemia and whether anyone checked her glucose level. By the way, this was my case in the exam, okay? And the examiner insisted that I should have asked about hypoglycemia and convulsion, despite that there is no history of loss of consciousness and there is no, usually hypoglycemia will present with generalized manifestations, not like focal neurological deficit. We are dealing here with focal neurological deficit, but still he wanted this. He wanted you to explore hypoglycemia and convulsions, okay? So after you analyze the weakness, you have to complete this by finishing your Reuters scoring, okay? So whenever I have a complaint in the CNS, the system involved will be the CNS. I will start exploring the CNS in more details. So here, I'm going to make sure that I cover the Reuters score or the Rosier score. Is it clear?
Yeah.
Okay, so just a minute. Then after that, I'm going to move to analyze the other complaint, which is the headache. Okay, headache you can analyze as usual using OCD, AAA, SSN, or Socrates. Okay, I have developed my own, which is Socrates. Okay, site. Okay, of the headache. Is it unilateral? Is it generalized? Okay, and with site usually we ask about the radiation. And when I'm speaking about headache by radiation, I mean, does it go down your neck? Okay, headache which goes down the neck or causing neck stiffness might point toward meningitis or subarachnoid hemorrhage, right? Then, just a second. Then the onset. Okay, onset of the headache. And usually with onset, we do ask about the triggers because trigger is the cause of the onset. If I have a knee pain, which started after trauma, trauma is the trigger, okay? And trauma is the cause of the onset. This is why the knee pain started suddenly. Okay, so with site radiation, with onset, trigger, and then the nature. Is it throbbing? Is it dull aching? Okay, and with the nature, I'm going to ask about the severity because severity is another description for the nature. If you ask someone about his headache, what is the nature of this headache? It is throbbing, doctor, and it is so severe. So severity is basically part of the nature. So with nature, I will ask about severity. How to ask about severity? It is going to be scale. So in scale of 0 to 10, 10 being the most difficult headache, the most severe headache, how would you score your headache? In a score of 0 to 10, 10 being the most severe headache, how would you score your headache? Okay, regardless of his score, take the time to offer painkillers. This is very important. Okay, don't worry, I'm going to offer you painkillers to help with this headache. This is very important because if you do not give painkiller, it might affect your clinical judgment. The patient is in pain, you have to describe painkiller. This is the reason why he is here. You have to solve this issue. Did you get this, Dr. Uday? Then the C is for course.
Yes,
Is it
sir,
getting
definitely.
yeah. Is it getting worse? Is it getting better? What does make it worse? What does make it better? Okay, and then any associated symptoms. Any associated symptoms. In case of migraine, you would expect like nausea. Okay, if it is related to increased intracranial pressure, then projectile vomiting. Okay, and that's why the last letter, which is T, is for timing. Timing. Okay, is it getting worse at the end of the day or early morning? Usually, headache of increased intracranial pressure is associated with. Usually, the headache is early morning. Early morning. Okay, so we did finish analysis of the main complaint, whether the headache or the weakness. And then because we have got headache and we have got arm weakness, so the system involved is the CNS. We did analyze the CNS covering our Rosier score. So far, we have detected that the most likely diagnosis is complex migraine. But again, we cannot exclude TIA because the Rosier score is +1. Okay, then I will move to the constitutional symptoms. Constitutional symptoms, okay, I mean the general symptoms, fever and night sweat, weight loss, lumps and bumps, appetite, skin itching, and so on. Okay, but most importantly here, I would want to think about fever. Why fever? Because if this patient is febrile, what could be the reason behind her headache? It could be meningitis. Okay, it could be infective endocarditis with thromboembolic complication resulting in TIA. So fever is very important here. Okay. So if I would like to think about the differential diagnosis for this particular case, if I would like to think about the differential diagnosis about this particular case, any idea what could be the differential here? Someone to help us?
Yes, hemiplegic migraine and TIA.
Excellent. Excellent. So the first, or on top, I will put complex migraine, which is hemiplegic migraine. Then the second differential is going to be TIA. TIA, we cannot exclude it in this case. But what could be the differential diagnosis for TIA in this particular case? Why this lady developed TIA?
Of thoughts paralysis.
Thrombophilia maybe, because mother has had a
Excellent. Excellent. So familial thrombophilia, right? Someone
Yes.
mentions thought paralysis, but against that, there is no seizure activity, right? What else?
About antiphospholipid history.
It was negative. There was no history of abortion or clots.
Carotid artery dissection.
Excellent. Carotid artery dissection is definitely one of the differentials here. Okay.
Carotid
So I
sinus
asked Dr.
syndrome.
Uday, I asked Dr. Uday a question. How does carotid artery dissection or cervicocephalic dissections in general might result in TIA?
It is
Usually it will result in
Infarction. Cerebral
When there
infarction.
is tear in the carotid, there is might clot be formed.
excellent.
And
Excellent.
it
Yes.
can be,
Exactly.
go to the brain.
Exactly. So you have got arterial wall injury. Okay, they will be platelet aggregation and clots formation, and then this clot might detach, traveling everywhere, and it might result either in TIA or stroke. Okay, other presenting problems with cervicocephalic dissection, the patient might present with like pain in the neck, swelling in the neck. This is very important. You have to ask about neck swelling and neck pain. What else? Audible bruit. Audible bruit. He will hear the bruit in his ear. Pulsatile tinnitus. Sometimes it might present with pulsatile tinnitus. Sometimes it might present with migraine-like picture. Migraine-like picture. So the patient might not have neck pain, but he will have migraine-like headache. So despite she denied neck pain and swelling, still I can put cervicocephalic dissection in the differential, especially she develops these symptoms while extending her neck in the hairdresser. Okay, so first differential is complex migraine. The second differential is TIA. The first differential for TIA is going to be cervicocephalic dissection. One of the doctors also mentioned familial thrombophilia because she has got her mother. She has got family history. Her mother developed stroke at the age of 55, and she was on warfarin. So there is a possibility of familial thrombophilia. Familial thrombophilia. What else?
Hypersensitivity. Carotid sinus hypersensitivity.
A carotid sinus hypersensitivity, I would expect the patient to lose his consciousness, to develop syncope, but not weakness. Not weakness.
OCP per se is a risk factor for.
Excellent, excellent. Per se is a risk factor, and more importantly, because this patient has got migraine. Combined oral contraceptive is contraindicated in patients with migraine because it increases the risk of stroke and TIA. So if you do not stop this patient from taking oral contraceptive pills, this will definitely affect your clinical judgment. Never forget to stop the combined oral contraceptive pills in this lady. But I am not going to tell her that I will stop the oral contraceptive pill. She took it for a reason, right? She don't want to get pregnant. So the best solution is to offer review by the woman doctor. Exactly. Okay. He will select a suitable birth control method for you. So if I ask you what kind of birth control method might be safe in patients with migraine? Progesterone only pills, right? Progesterone only pills. It can be injection, it can be implant, whatever. Even also intrauterine devices. Okay, or even the mechanical barriers, but not combined oral contraceptive. Is it clear? So the first differential is complex migraine. The second differential is TIA. TIA itself has got a differential: cervicocephalic dissection, familial thrombophilia, oral contraceptive pills in association with migraine. Oral contraceptive pills in association with migraine. Okay.
Doctor, can we say sickle cell disease?
Sickle cell disease can cause, yes, sickle cell disease can cause stroke in young, but nothing here to suggest sickle cell disease. No symptoms of anemia, no pain suggestive of any crisis.
Okay, doctor, thank you.
Okay, but we can suggest other acquired causes of thrombophilia. We mentioned familial thrombophilia, right? And at the same time, it can be also acquired thrombophilia, like what? Like polycythemia rubra, like Bahjat disease. So it's important to ask about itching, especially after hot bath. This is for polycythemia rubra. For Bahjat disease, any oral ulcer, any soreness in your mouth, any soreness in your private area. Okay, so this is a way to think about the differential diagnosis. Then, after you cover the main complaint and the system involved and the constitutional symptoms, and after you cover the differential diagnosis, then you will move to cover the rest of the systemic review. Okay, you did ask about the cardiopulmonary system, Dr. Uday, the GI and the genitourinary system, okay, and the CNS, but you missed to ask about the musculoskeletal system. Musculoskeletal system, joint pain and swelling is very important, okay, because there's a chance that this lady has got any connective tissue disorder in association with antiphospholipid syndrome, okay? So it's important to ask about the musculoskeletal system, okay? Female history, you did ask about the female history, okay, but try to complete the 5 Ps in any station 2 case, 5 Ps, okay? I mean, pregnancy, period, pills, recent baby, abortions, okay? Because I would like to know whether this patient has got antiphospholipid syndrome or not, okay? So if I ask you a question, if this lady was found to have DVT, how can you justify the development of TIA or stroke in such patient?
Patent from an oval or
Excellent, excellent, exactly. Exactly. Okay. So after I finish, again, please, doctor.
Long distance traveling or flying.
Long distance traveling is important, but this will cause DVT, right? So if she has symptoms of DVT, then I would like to explore the rest of the risk factors or risk factors for DVT. Okay, so better than asking about the risk factor for DVT, ask about DVT itself, because you have got a lot of differentials here to explore. If she has DVT, then I would want to think about paradoxical implants through patent foramen oval, and here it's a must to reach to search for the underlying risk factors. Got the point? Clear?
Yes, doctor.
Okay.
Yes,
then after you finish the systemic review and the female history, you will move to your PDFs. P for past medical history. She has only history of migraine. D for drug history. Positive findings were oral contraceptive pills and occasional over-the-counter painkiller for the headache. Family history. Mother developed stroke at age of 55 and she was on warfarin. So here, this is why we suggested familial thrombophilia. Then I will move to social, smoking, alcohol, and so on. Okay. So as soon as you finish, you have to explain, of course, to your patient. Okay, you have to explain to your patient. How do you explain to your patient? First, I will explain the diagnosis. Second, I will explain the management plan. Third, I will cover my clinical judgment. I will repeat again. First, I will explain the diagnosis. Second, I will explain the management plan. Third, I will cover my clinical judgment. Okay, so in any disease, how to explain to the patient? First, you will start by the symptom. Okay, your weakness and headache is related to, here I will mention the disease, is related to migraine. Migraine sometimes might cause such weakness, and it is called complex migraine. Here I mentioned the diagnosis. It is called complex migraine, okay? But because of the unusual presentation, she mentioned that the current episode is not like the previous episode. Doctor, it is severe. Doctor, it is involving my entire head. Doctor, I developed weakness for the first time. So this is unusual or atypical presentation. I am not going to say atypical presentation because this is technical term. I will tell the patient that because of the unusual way or unusual presentation, we need to exclude the possibility of mini stroke. I'm not going to mention TIA because TIA is jargon. Here I did explain that her symptoms are attributed to this diagnosis. I told her the diagnosis, okay? Then I am going to move to the management plan. We need to run some blood tests to do some scanning into your brain. I'm not going to mention MRI or CT, scanning to your brain. And we will get you seen by the nerve doctor within 24 hours. This is very important, by the way. This is very important. You have to suggest neurologist assessment within 24 hours. Why? Because recently, not recently, it is old now. There is guidelines since July 2019, nice guidelines. Any patient with suspected TIA or stroke should be seen and assessed within 24 hours by neurologists. So if you do not mention this clearly, it is going to damage your clinical judgment. Okay, so we will run some blood tests, we will do scanning to your brain, and we will get you seen by the nerve doctor, not neurologist. Neurologist is a jargon. We will get you seen by the nerve doctor within 24 hours.
Sorry, doctor. Regarding
Yes, doctor.
CT or brain scan, should be requested by me or by the nerve doctor?
According to the guideline, you should start aspirin 300 mg after you exclude bleeding, and then get the patient assessed by neurologist within 24 hours. Okay, basically the neurologist will be like with you in the hospital. Okay, it does not make a difference whether you request a CT or not. Okay, because according to the guideline, either should be seen by neurologists within 24 hours if the neurologist with you in the hospital, or to be referred to stroke unit or to stroke physician within 24 hours. Okay.
Okay, so I have to request the CT to rule out bleeding first.
Yeah, no problem. You can request CT, okay, and then contact the neurologist immediately because he has to see the patient within 24 hours. Okay.
Okay, thank you.
And you should start also aspirin 300 mg if bleeding was excluded. Okay. So here I did explain the diagnosis. I did explain the management plan, investigations and a scan and neurologist. Okay. Then I have to make sure here that I covered all my clinical judgment. This is very important. How to make sure that you did cover your clinical judgment. Just a minute, I'm going to share another picture.
No need for admission.
So Abbas driving. I made a mnemonic just to remember which clinical judgment point I need to cover. Okay, this is applied for most of the cases. Okay, but sometimes there is others also you need to add according to your case. So the A is for admission. This is the first question you need to ask yourself. If, for example, the patient is dehydrated and you did not mention to him that we need to admit you to hospital to give you fluids to correct your water loss, they will deduct marks out of your clinical judgment skill. If the patient is not for admission, okay, then you need to tell him which specialty he needs to consult. For example, are you going to manage him as outpatient? You have to tell him. Are you going to refer him to the joint doctor, nerve doctor? You have to tell him. In our case, we did involve the neurologist within 24 hours. Okay. Then the P is for painkillers. As we mentioned, this patient has got headache. I'm going to offer painkillers. Has got abdominal pain. I'm going to offer painkiller. Joint pain, any pain, you have to offer painkillers. Then the A is for alcohol. If the patient is drinking over the limit, you have to advise to moderate alcohol consumption. Then the S is for smoking. This patient is a smoker. Okay, so I have to advise her to stop smoking. And the D is for driving. Okay, but here, by the way, it is completely fine to mention to the patient, for now, you need to stop driving and notify the DVLA. I'm not sure whether you should stop driving for now, because still we need to establish the diagnosis. Okay, but after thorough assessment, okay, the DVLA will give you advice whether you can continue driving or not. Okay, on my responsibility, you can mention this to the examiner, because I did mention this to the examiner. I got the full mark, because they do not need full knowledge about the DVLA rules and regulations. They want you to be a safe doctor. For now, to be safe, you stop driving until further assessment and notify the DVLA, full stop. This is applied for most of the cases, but if we want to add a specific point for our case, you have to stop, as we mentioned, you have to tell her that we will refer you also to the woman doctor to select suitable oral contraceptive pills. What else we can add here? Very important point. Triggers. They mentioned, by the way, it was mentioned from outside in the scenario that she dropped the cup of coffee and started to develop weakness in her left side. Okay, so I advise you to moderate your caffeine intake. Try to avoid cheese and chocolate, because these certain types of foods are known to trigger migraine. Okay, is it clear? In this way, I did cover all my clinical judgment points. Is it clear?
Yes, clear.
Okay, so one of the patient concerns, do I have a stroke, doctor? No, it is not a stroke, but there is a possibility of mini stroke. Okay, the main differential or the most likely cause is complex migraine, as I mentioned, but still we cannot exclude mini stroke. But no, you do not have a stroke. Will this happen again, doctor? Will this happen again, doctor? How are you going to manage this concern? So first, we need to identify the cause. If we establish the diagnosis of complex migraine, then the nerve doctor will start you on medications to prevent this from happening again. The nerve doctor will start you on medication to prevent this from happening again. If it is a mini stroke, we are going to treat any condition that put you at risk of this. If it's a mini stroke, we are going to start you on a medication. We are going to treat any condition that put you at risk of this. As you can see, I mentioned the nerve doctor is going to start you on a medication. Why? Because, by the way, beta blockers are contraindicated in complex migraine. Topiramate is controversial. There is a lot of dilemma going on over the prophylaxis for complex migraine. I don't want to know it for the purpose of the exam. Why? Because you can give a smart answer. The examiner did ask me about this, by the way, and he wanted me to say beta blockers so that he can take score out of my clinical judgment. Okay. Anyhow, this patient, by definition, according to the new guideline, he has to be seen by a neurologist within 24 hours. Let the neurologist assess him for TIA and at the same time give a proper prophylaxis if the differential diagnosis of complex migraine was confirmed. Does it make sense?
Yes, definitely.
Definitely, right? Okay. So other concerns was, can I continue to take the pills? Okay, we did answer this, that she will need to select another suitable contraceptive. Can I drive? If it was TIA, of course, she will stop driving for 1 month, but still the diagnosis is not confirmed. So it is totally fine to advise her to stop driving for now and then notify the DVLA for further advice. Differential diagnosis, now we will move to examiner's question. Differential diagnosis, as we mentioned, okay, investigations. We mentioned general investigations, okay? And then I will not say CT or MRI. By the way, MRI is more suitable in this case. Why? Because you do not expect this patient to have hemorrhage. Why? Because the symptoms already improved. Usually hemorrhage will not go away on its own. Okay, TIA usually is related to thrombosis. So MRI is better to detect any evidence of ischemia, and also at the same time, it might exclude other diagnoses like multiple sclerosis. You can see the plex of multiple sclerosis. Even sometimes cervicocephalic dissection might be detected in MRI. Okay, but again, I'm not going to say neither MRI nor CT. I'm going to say MRI, MRV, MRA. MRI, MRV, MRA. MRI, as we mentioned, to rule out bleeding and ischemia and plex of MS. Okay, MRV to rule out CVT, cerebral venous thrombosis. MRA to rule out cervicocephalic dissections. And then you can mention autoimmune screening if indicated. Okay, management, we already covered the management. So any questions so far?
For neck ultrasound,
MRA is angiography, by the way. So it's fine. Anything just to explore the possibility of cervicocephalic dissection.
Dr. Hussam?
Yes?
Is the time relation between the weakness and headache make any difference in the complex migraine?
Yes, definitely. Definitely. Actually, complex migraine, just like an aura to the migraine. So the weakness will start first and then the headache. This is important question, okay?
Okay, shukran.
All right, Dikalaka. So regarding the new PACES format 2023, we are going to try to apply the same scenario, okay? Just because we are running out of time, we are going to discuss the same case as station 2 and station 5 according to the new PACES format. So regarding the new PACES format, there is a lot of changes going on. Like the total score was 172. Now the total score is going to be 168. 168. We will lose 4 marks, okay? Because skill D, the differential diagnosis, it was 28 total marks. Now it is 24, and this is basically because they canceled the history station. Before we had 2 station 5 and history, right? Now the history is canceled. In place of the history, they will put another long scenario, and station 5 is going to be one long scenario. Okay, and this is why also the total score went down from 172 to 168, because the history station was total mark of 20. You took away the history station and you replaced this with another communication scenario, which is scored 16. 20 minus 16 equals 4. That's why the score now, the total score is 168 instead of 172. Okay. Then the minimum score to pass the exam, it was 130. Okay, or it's going to be 130 up to day 2. But then according to the new format, it's going to be 127. 127. And again, you have to pass all the 7 skills in order to pass the exam. The skills assessed is going to be the same. Skill A, B, C, D, E, F, G. It is going to be the same, no changes. Okay, just there is very minor changes to the way they assess the skills. Like in skill A, for example, which is physical examination. Okay, everything stays the same, but now if you lack the confidence, and if you examine over clauses, if you do the examination over clauses, for example, your patient has got a back pain, okay, and you check tenderness over the clauses, they might mark you as unsatisfactory and give you 0 in skill A. Is this clear? So take care, please. Never do the examination over the clauses. Sometimes the patient might be a surrogate, like the case which came in Royal Hospital. He was one of the nurses in the hospital, basically, okay, wearing nice, tight scrub suit. Okay, so most of the candidates did the examination over the clauses because since he's a surrogate, they did not think that there will be any positive findings. So they just did the examination for tenderness over the clauses, all of them. Okay, they were minus in skill A. At that time, it was not written clearly in the instruction that you cannot do the examination over the clauses. From now on, it's going to be official. So never, whether you are going for day 2 or day 3, never do the examination over the clauses. This is regarding skill A. Skill C, here, they added something, okay? In addition to the previous version of this skill, they added that you have to identify patient preferred management options. Patient preferred management option. What do you mean? If you fail to take the patient opinion and to involve the patient with you in planning for his management, they will give you 0 in this skill, skill C. So make sure whenever you suggest the management plan to ask the patient, what do you think? Okay, any concern? Do you agree? Okay, to give the examiner the sense that you are taking the patient on board with you when planning his management plan. Is it clear?
Again,
In
please
skill F,
explain.
yeah, just in skill C, which is communication skill. Okay, everything stays the same, except they added that you need to demonstrate that you are involving the patient with you while outlining his management plan. Okay, and you are considering the preferred management option by the patient. Just demonstrate that you are discussing the management plan with the patient. Okay, you are reaching a management plan together, okay? Otherwise, if you fail to demonstrate this, they might give you 0 in communication skills. They will give you unsatisfactory. Unsatisfactory equals 0, okay? Then in skill F, which is managing the patient concern, everything stays the same, like appreciate the concern, acknowledge the concern, try to address the concern, and then check understanding, okay? But they added demonstrate active listening. Demonstrate active listening. Basically, they are trying to make the examination more real, to represent real life scenarios. Okay. Some of the candidates use like to go to the exam, okay, and then they will start just speaking. They have got a fixed frame they want to finish. They will just start speaking and explaining. They will not allow the consultation to be too directional. Okay, the correct way to save your skill F, to save the skill of managing patient concern, is to keep the consultation too directional. What do you mean? You will give the patient information, okay? Then you will wait for his response and then check understanding. Both of you should be speaking. Okay, you have to demonstrate active listening. Active listening. Listen carefully to what he is saying. Okay, don't be robotic. Okay, apart from these three skills, A and C and F, the rest stays the same. Okay. So this is regarding the scoring. Okay, regarding the skill assessment, regarding the timing for station 2 and 5. Station 2 and 5. Okay. Now both of them are going to be long case scenario. Long case scenario. Okay. Each one of them, whether it is station 2 or station 5, is going to be 20 minutes. The total duration of the station is 20 minutes. Before this 20 minutes, they will give you 5 minutes to prepare for the case. And this is very nice, by the way. This is very nice. People who are going for the 3 are lucky. Why? Because previously, in station 5, they will give you 5 minutes to prepare for 2 cases. This means like less than 2 minutes to prepare for each case. Now you have got 5 minutes to prepare for each one of the cases, okay? Because each case is in a separate station. Is it clear? So the
Doctor,
5 minutes, yeah.
It will be 3 cases, session 5 instead of 2?
No, two cases. Station
Cases.
2 is going to be a long case, including examination and history. Station 5, again, long case, including examination and history. Before session 5 was 2 cases, right? Now it is only 1 long case. Station 2 it was history only. Now it is another long case, which includes examination and everything. Got the point? And for each one of them, you have 5 minutes to prepare.
And regarding communication skills will be the same.
Communication skills, I don't want to dive in details in communication skills because we have no time, okay? But it's going to be 10 minutes, okay? So you can prepare in a paper and pen, okay? People who are going for day 2, they don't have this luxury because there is no time. You cannot look in your paper because the total duration of the station is 10 minutes, only 8 minutes with the patient. 6 minutes to take the history and examination. So it's impossible to look over your paper and then come again. But day 3, you can prepare, you can write in your paper, you can take the paper and pen with you to the station, you can look into your paper to remind yourself about the differential. It's going to be very nice. And there is no time strain. Time management is going to be easy because you have got 15 minutes with the patient. Instead of 8 minutes, you will have 15 minutes with the patient. Okay, when 13 minutes passed, after 13 minutes, the examiner will tell you 2 minutes remaining. 15 minutes with the patient, and then 5 minutes for examiner questions. 5 minutes for examiner's questions. So Diet 2 candidates, they have got only 2 minutes for the examiner's question. So the examiner will be rushing you. Okay, when you start to mention the positive finding, he will start to interrupt you. So how are you going to manage your patient? How are you going to investigate? How are you going to treat? Because he has only 2 minutes to cover all this. But day 3, he has got 5 minutes. Okay, so he will expect the examiner to ask you in details about the findings, about the differential diagnosis, about the management plan, about the investigation, about everything. Okay. So I advise you to take history in around 6 to 7 minutes. Okay, 6 to 7 minutes only for history taken, pure history taken. Okay, and by the end of the history, immediately ask the patient about his concern. Why? Because sometimes the concern raised by the patient or by the surrogate will alarm you to do some examination. Did you get this?
Yes.
The patient concern might help you in your examination. So by the end of the history, ask the concern immediately. And the second reason, the patient is not going to have 1 or 2 concerns. He might have 3, 4, maybe 5 concerns. Okay, it is not like in day 2. He will have 1 or 2 concerns maximum. What do I have? Is it treatable? Full stop. But here he might ask you, is it treatable? Is it controllable? How are you going to treat me? What investigations we need to do now? Okay, will this happen again? Will this affect my kids? it is going to be 3 or 4 concerns. Okay, so I will ask about the concern or concerns, plural. Okay, after the history immediately, 6 to 7 minutes for the history. Then I will ask about the concerns. Okay, and after he tell me the concern, I'm going to tell him, okay, I will answer this in a minute. First of all, I need to examine you first. I need to examine you, okay, and then later on, you might want to do some blood tests and scanning and so on. Okay, so it will be like a permission for the examination. Okay, I will answer all of your questions in a minute. Before that, I need to examine you first. Is that okay? Yes, doctor. Then here, you will start the examination. Usually, the examination will not take more than 4 minutes. Usually, it is not going to take more than 4 minutes. Okay, then you can get back to discussion with the patient. Okay, so 6 to 7 minutes for history. Then ask him about the concern. Let us say that you took 1 minute. This is total of 8 minutes. Then 4 minutes for the examination. This is 12 minutes. Okay, then you have got 3 to 4 minutes in average to explain to the patient the diagnosis and the management plan, and to answer his concern, and to cover your clinical judgment point, and so on. Is it clear? Any question regarding the timing or the time management?
Okay, doctor, is this for session 2 or 5?
Both of them, because both of them now are the same. Day 3, they are going to be the same, exactly the same. Long case, 20 minutes. Okay?
Thank you.
Clear? So let us assume I am going to, I am going for day 3, okay? And I am in session 2 or in session 5. It won't make a difference because both of them are long case. Long case, I have got 20 minutes. Before this 20 minutes, I have got 5 minutes to prepare myself. So I got the same scenario we just did as history. Complex migraine and TIA, blah, 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 okay? So 5 minutes, I read the scenario, I prepared my differential, I prepared my paper, then I entered the station. I introduced myself, I confirmed the patient identity, I confirmed the meeting agenda, I took permission from the patient that I would like to ask you a few questions, and at the same time, I will examine you. I would like to examine you. By the way, it's totally acceptable to ask questions, examine the patient, then go back to history, and then go back to examination. مصارعة حرة. Everything is permissible. Okay, you can do everything. Okay, so after that, I'm going to ask him open question and then take history, the same history we did today. In, let us assume we did this in 7 to 8 minutes or 6 to 8 minutes. Okay, just quick history. Then after that, I'm going to ask her about her concern. Any concerns have you got? Doctor, is it a stroke? Doctor, will this happen again? Doctor. Okay, so I will answer all of your questions and concerns in a minute. Before that, I would like to examine you if that is okay. I would like to examine you if that's okay. Yes, doctor, please. So I am going to examine her. How are you going to examine such patient? So examination, whether you are going for station 5 in day 2 or station 2 and 5 in day 3 is almost the same. The general idea is the same. The only difference is session 5 in day 2, you have no time. You have no time, you have to be quick. Day 3, you have a lot of time, you have plenty of time, more than 4 minutes. You can do whatever you want, okay? But the general idea is fixed, VLS. VLS. V is for vital chart. L is for local examination. I mean examination of the main complaint. S is for general survey or general examination. So you're starting by the V, vital chart. Most of the cases are going to be mentioned from outside, especially for people going for day 2 because there is no time. So before I start examination, I have to make sure that I ask about the vital chart. In this particular case, as we mentioned, in the history, fever is important. So I want to make sure that this patient is not febrile, because if he is febrile, I will be thinking about infective endocarditis with thromboembolic complications resulting in TIA. I will be thinking about infections like meningitis. So fever and vital chart in general is very important. After the vital chart, I will come to the L, which is the local examination, which is the examination of the main complaint. What are the main complaint in this case? Weakness and headache. Weakness and headache equals CNS. So I will start by examining the CNS. This patient is complaining of left side weakness. So I want to make sure that this patient has no residual weakness, because by definition, this is TIA. So just quickly, I'm going to screen power, reflex, sensation, coordination. Okay, I'm not going to do full neurological examination. No, this is not required in station 2 and 5. It is not required in station 2 and 5 in day 3. And also it is not required in station 5, day 2. Just quick assessment, okay, like pull my fingers toward you, okay, or do like this for me. Just crude assessment for the power, but I'm not going to examine all the specific groups. Just crude assessment for the power, okay. And at the same time, I can ask her any residual weakness at all, okay. Can you move your arms like normal? Just crude assessment. Power is done. Sensation, just using both index finger and middle finger in both arms, in both hands. I will just touch her over her upper limbs bilaterally. Okay, do you feel this here? Do you feel this here? Just to crudely assess sensation, to touch only. I'm not going to do vibration and position sense, and no need. Just quick assessment for sensation. Then I am going to assess coordination by finger to nose test. Cerebellum is done. Okay, show me your teeth. Show me your teeth. Just quick assessment to know whether she has got any facial pulse. Facial pulse. Okay, then my local examination is done. Neurological examination is done. Thorough neurological assessment. It is not like station 3 here. No. Only quick assessment. Is it clear? So the vital chart finished. The local examination finished. I mean examination of the main complaint. I will come to the general survey. General survey or general examination. For this particular patient, we are speaking about stroke or TIA in the young, atrial fibrillation, polycythemia rubra, DVT, antiphospholipid syndrome, a lot of differential. How to cover all these differential within the general survey. I will start by examination for the pulse. Pulse for atrial fibrillation. This is the first station. The second station, I'm going to move to the face. Look for any plethoric face. Plethoric face, red injected conjunctiva. If you detected any redness in the face, plethoric face, erythematous face, red injected conjunctiva, immediately I will ask her, have you got any skin itching, especially after hot bath? Any blurred vision? Any idea what I am asking about now? Itching after hot bath, blurred vision, headache.
Polycythemia, hyperviscosity.
Hyperviscosity, exactly. Hyperviscosity syndrome, which might indicate polycythemia rubra. So the first station, pulse for atrial fibrillation. The second station, face for polycythemia. Then I will move to the pupils. I will inspect quickly for Horner syndrome. Horner syndrome. Why Horner? Because cervicocephalic dissection sometimes will cause Horner. I'm not going into details now. But anyway, you need to inspect the pupil for Horner because one of your differential is cervicocephalic dissection. Then I will move to the mouse. You can ask or examine, just one of them. Don't do both. You can either ask her about soreness in the mouth, or you can inspect the mouth for mouth ulcer. And at the same time, you are not going to examine, of course, the genitals for genital ulcer, but you will take the chance to ask about genital ulcer at this stage. Okay, I will ask her or examine for mouth ulcer, and then I will stop to ask her about any genital ulcer. What could be the differential if this was positive?
Sorry again, doctor, please.
Bahjat.
disease.
Mouth ulcer, genital ulcer. Bahjat
Just
disease, exactly.
Bahjat disease.
Exactly, excellent. Okay, then I will move from the mouse. Still, I will move down. We are coming back in a sequence, by the way. Pulse, face, eyes, pupils. Okay, then mouth, then neck. Here in the neck, I will stop to ask about neck pain and swelling. Neck pain and swelling. Okay, what could be the diagnosis if this was positive for a patient who was extending her neck in the hairdresser and developed weakness?
Carotid artery dissection.
Exactly, carotid artery dissection or cervicocephalic dissection. Sometimes it is the vertebral artery, by the way, or the basilar artery. So better to say cervicocephalic dissection, okay? Then I will move down from the neck to the chest. Any murmur. If there is murmur, what could be the diagnosis?
Could be patent foramen or vein, could
Cardiac.
be endocarditis.
Let us mention the collective name first, which is cardiac thromboembolism or thromboembolism of cardiac organ, okay? Then you can check for like small joint arthritis or skin rash or livedo reticularis, because this might point toward antiphospholipid syndrome, especially if this patient mentioned history of abortion or clots in her female history. Okay. At the very end of your examination, you can suggest fundus examination to look for papilledema. Okay. Usually, the patient, especially if you are going for the then after you finish your examination, you are not going to be speaking to the patient. You are going to be speaking to a surrogate who will give you the history, but you will examine the patient, okay? So after you finish the examination, you will come back to the surrogate or the patient, whatever, and then you will discuss the diagnosis exactly as we mentioned. You will discuss the management plan exactly as you mentioned. You will cover your clinical judgment exactly as you mentioned. Examiner's question is going to be the same. Summarize your case. What is your positive finding? What is your differential? How are you going to investigate this patient? How are you going to manage this patient? This part is already covered. So any question? Is it clear?
Dr. Hussam,
Yes, please.
the history will be focus history. I mean, in the new format of PACES. Like I will
It is not.
omit
It is not.
the systemic review.
Yeah,
and
I got your question. Yeah, it is not mentioned in the examiner's assessment sheet. It is not like station 2 before. Station 2, it was mentioned clearly. You have to ask. You have to analyze the main complaint. You have to ask about the past medical, family history, drug history, social history. It was mentioned. And if you omitted any part, it is going to affect your communication skills. Okay, so in session 2, for people who are going for day 2, definitely you have to ask about all aspects of the history. For station 5 and station 2, for people going for day 3, no, it is not necessary. It is not written in the examiner assessment sheet. But what is required from your side is to cover all the relevant history. What do you mean? If, for example, some part of the history was not relevant to my case and I did not ask, they are not going to deduct any marks out of my score. But for example, in this case, it was positive for family history of stroke and I did not ask about it. Definitely, they will deduct some marks.
Okay.
Okay.
Thank you.
Welcome. Any other question?
Please, doctor, for case of today, In
Yeah.
case of fever with hemiplegia, can we consider also herpes encephalitis?
Herpes encephalitis. Encephalitis usually will present like
Seizure, I
with
know, but
generalized neurological deficit, like yeah, exactly, seizure, loss of consciousness. But definitely you can consider, yes, any infection. We mentioned infections like meningitis, so infections will cover other types of infections like encephalitis. Okay.
okay, because meningitis usually caused sometimes that just only is a sixth nerve palsy, because not hemiplegia, as I know.
Yes, yes.
Or
In
can
general,
can cause thrombus. Yes, can complicate with thrombosis.
yes, definitely you are correct. But you cannot omit meningitis in any patient who has got headache and fever, right?
Yes, okay.
That's,
Even
yeah,
hemiplegia,
yeah,
yes.
yeah.
Okay, thank you.
Yeah, exactly. Thank you.
Is there a can I took Takayasu? The differential?
Again, please.
If there is fever, can I took Takayasu?
Takayasu usually will present with symptoms like headache in unequal arm pulses. But in this case, I do not think that there is any particular something to suggest Takayasu. Why you said Takayasu? Anything in particular?
No, just vascular disease and fever.
So you can mention vasculitis in general, right? Vasculitis in general, not particularly Takayasu. Because Takayasu is a large vessel disease. It will cause aortitis and unequal arm pulses and so on. Still, of course, you can include in the differential. Okay, but better to mention vasculitis in general. Okay. So sorry, we are running out of time. Anyhow, if you have got any question, I will open the groups for discussion today. If you have got any question regarding the new PACES 23 format, or regarding our today's question, or any question, please do not hesitate to post it to the groups, and I will try to answer whenever I find the chance. Okay. So thank you for attending the session of today. See you next session, inshallah, and good night.
Okay, thank you.